name is Shakiba Enayati, and I'm recently joined Supply Chain and Analytics Department in the College of Business Administration at University of Missouri, St. Louis. Before joining UMSL, I was employed at State University of New York, Plattsburgh in the business school as well. I got my Ph.D. In operations research from North Carolina State University, and my background is industrial engineering. That's what I got my bachelor and master's degree from. So today I'm going to present optimal influenza vaccine distribution with equity, which is, well, I've planned for this to be very timely research. I'm going to talk about it, how that happened. So this work is in collaboration with my PhD advisor, Dr. Osman Ozaltin in Industrial and Systems Engineering Department at North Carolina State University. So before I start, I just want to again remind you, if you have any questions, feel free to chat with Renata or ask away in the middle. I think it would be very beneficial if we have an interactive presentation. So before I start the presentation, a little about my research interests and my research roots. So I'm interested in theoretical and computational aspects of operations research with applications in healthcare operations management. In particular, I focused on improving service quality in emergency medical service systems under realistic operational limitations as my PhD dissertation at NC State. I'm also interested in infectious disease modeling. The work that I'm presenting today is in this category. And in particular, I'm working more on designing and distributing vaccine under uncertainty of vaccine efficacy, prevalence of infection, and geographic and health disparities. And also, I'm interested in the application of supply chain network design, in particular, supplier selection problem, location problem, considering customer preferences and the possibility to deal with unreliable facilities. So, having said that, I would like to start with our talk. So a little motivation. So before we start dealing with COVID-19 and the whole surprising aspects of it, we were dealing with influenza very frequently, like every season, every year. 5 to 15% of the world's population was infected with influenza, resulting in 3 to 5 million severe cases and up to 500,000 deaths. So influenza still is a serious public health concern. We are dealing with something similarly serious or even more serious, but very similar in nature. And so this research was done a couple months before WHO announced that we are dealing with pandemic, but now this is very relevant these days. So influenza with pneumonia has become the top 10 leading causes of death in the United States. So it's still very serious. So vaccination is the principal intervention for reducing this problem. So the role of vaccination is to looking at this, let me show the laser so that you see, yeah. So, so you are in the population, you're having some susceptible individuals that are shown in the light blue color. So the healthy people that are not immune to the disease. So the role of vaccination is to make some of these individuals, depending on the proportion of people that you would end up vaccinating and also the effectiveness of the vaccine, the role is to make some of them immune so that at the end you deal with less number of sick people in the population. So that's the role of vaccination. And this is one of the most effective interventions that when it comes to infectious diseases. So a little about how the vaccine is produced. So for an infectious disease like influenza that is known and the vaccine is up and running, So what's happening normally is the vaccine is produced before the season. Looking at the southern hemisphere, they predict what is the strain that would circulate in the upcoming season. And then they will start manufacturing a few months in advance because there are some lag in production. So they start around April, May every year. They produce the vaccine against the predicted strain. But it is possible that a new flu strain emerges in the population after the vaccine strains are selected. And there's probably not enough time to produce enough amount of vaccine to contain a potential outbreak. So it is possible, even for a disease that is known, we will deal with some limited amount of vaccine. For COVID, that is very recent, we are dealing with this situation as well. But most likely, hopefully, if we have a vaccine up and running, we would be dealing with a very similar situation, just like flu every year. So if there is a new flu strain, then there would be a limited amount of vaccine. And then the question in this case would be, okay, what would be the minimum required doses of vaccine to contain a potential outbreak? And also how to distribute. And then just considering the fact that you're dealing with a heterogeneous population, meaning that not everyone in the population would have similar level of vulnerability and they won't be exposed in the same level to the disease. So the population is not completely homogeneous. So considering this fact, then what is the required doses to contain the pandemic and how to distribute it? So this question becomes even more critical when it comes to a limited vaccine availability and also when the vaccine efficacy is low. So I'm going to show you in the numerical result that the usual efficacy for the flu is 50 to 60% efficacy. And well, we are hopefully dealing with, for COVID, we're dealing with something around 90%, which is very promising. And also, when it comes to distributing public health resources, you want to make sure that whatever policy you're having is equitable. You want to have equity in order to have a practical solution. So for the rest of this presentation, I'm going to talk about the way that this problem was modeled. So I'm going to talk about how we developed the epidemic model for influenza transmission. And then I'm going to talk about how that model was coupled with a mathematical program to minimize the total number of vaccine doses to contain the outbreak. And then I will talk about how we handled the equity consideration in the model. I would briefly talk about our solution procedure, and then I'll show you some numerical results, and we will discuss some practical aspects for this problem. So first, talking about the model formulation. So we use the compartmental modeling, the famous susceptible, exposed, infected, recovered model. That is an epidemic model. So this is modeling different stages of the disease in the population. So some people are susceptible at the time, some are exposed, some infected, some recovered or removed. So we characterize the spread of influenza through interacting subgroups. So as I said, we are assuming that the population is heterogeneous, meaning there are different subgroups in every stage of the disease. So, and I'm going to talk about what means subgroup. So the subgroup definition is flexible. So you can think about a particular age group, like let's say a school children living in a certain geographic area. You can define it this way. Or you can define subgroup as healthcare workers or the residents in a nursing home. So depending on the population and the different aspects of the disease, you may think about the definition of subgroup differently. But that has nothing to do with the way that the model would work. So whatever you would define as a definition of subgroup, the model is designed generic enough to accommodate that. So but we assume that each compartment or each subgroup is homogeneous and individuals in the same compartment are identical and they mix uniformly among themselves. So in this figure, I'm showing the way that the transition is happening, and I'm going to walk you through the way that the disease, the influenza, would spread in the population from subgroup to the other. So starting with the first arrow, susceptible to expose. So susceptible are those healthy individuals that are not sick yet and they're not immune. So the susceptible individuals, they would go to the exposed stage of the disease with some rate that is called incidence rate. Don't worry about following the math. I'm just showing you the math, but what is important is just to get what are those important factors in every transition. So the incidence rate of transitioning from susceptible to exposed is happening considering different factors. One is contact rate. So people would interact with each other, they would have a contact rate, and then they get exposed to people who are infected. So the exposed individuals are those people who can infect others, but they are not symptomatic yet. So they are in the population, they can infect. So depending on the contact rates of different subgroups, so we are showing it with I and J, so people from different subgroups, for example, different age groups in a different geographic area, depending on their commute to work, going shopping, going to school, they will interact with each other. So that has a rate. So considering that, and also the susceptible individuals from different subgroups, they're not having the same relative susceptibility. They are not vulnerable in the same level. So the way that school children are vulnerable to disease is not the same as seniors, for example. And also the people who are infected, whether they're exposed, meaning they are not symptomatic yet, or infected, showing symptoms, they have a different level of infectiousness, and also depending on the subgroup that they're having. So considering the contact rate, relative susceptibility, relative infectiousness of exposed individuals, or relative infectiousness of infected individuals, susceptible individuals may transition into exposed compartment with an incidence rate. So moving forward, from exposed individuals, people would transition into infected stage of the disease. They would start showing symptoms, for example, influenza, after a couple of days. They would start showing symptoms. So we are assuming in this model that some people, some proportion of exposed individuals, before showing symptoms, they would do the social distancing. So we are seeing the impact of quarantine in this model. So a proportion of people would go to the compartment of quarantined people. So these people are infected, but they're not in the population. They can't spread the disease. So, and also the remaining of the proportion of that people are going to infected stage and they are in the population. They are not following the social distancing. And then moving from the infected or the quarantine compartment with some rate, after some time in influenza, after 3 to 5 days, they would recover, or perhaps they would be removed from that stage. So they would be in the R compartment. Alpha is showing the recovery rate or the remove rate. So in short, we can see that considering the interacting subgroups, the infectious disease is transmitting, and this is the set of differential equations showing this transmission. Don't worry about it, it's just the way that we would sort of translate whatever we talked about into math. So now that we have the epidemic model developed, now we need to make the decisions that we wanted to make. So what is the required minimum doses of vaccine in order to contain the outbreak, and how to distribute it? So in order to do that, I should introduce a concept that probably you've been hearing this thanks to COVID pandemic situation we are dealing with. The concept of reproduction number. So the reproduction number R of F is defined as expected number of secondary infections generated by one infected individual after vaccination. So
Shakiba, can I ask a question real quick? So all these things should be indexed by time, right? Like on the last slide, you had everything indexed by the individual, but like what's going on here is something over time, right?
Absolutely, absolutely. So do you see this? This is the differential equation. So this is in fact ds divided by dt. So it is the change of number of susceptible individuals over time. Absolutely. So this is in fact the rate that is happening over time. Did that answer your question?
Yeah, thanks.
Yeah. So going back to the reproduction number. So if you do not do any intervention, the reproduction number is called R0. So the R0 would determine the expected number of secondary infectious individuals generated by one infected individual. But if you have an intervention like vaccination, then that reproduction number is called R of F. So RF is shown that if it is less than or equal 1, then you can say if the expected number of secondary infectious is less than or equal 1, then you can say that the epidemic is contained and you can stop the outbreak. So considering that, we have a model in the literature by Hill and Longini in 2003, as you see here. So this model is minimizing the amount of vaccine distribution. So in this model, you have the decision variable F, that is the vaccine coverage in a subgroup. And it is between 0 and 1 because the fraction of the population in a subgroup that you would end up vaccinating. So Hill and Longini in the literature, they characterize all feasible solutions for this model. So the problem with this model, the difficulty is this constraint. So this constraint would address stopping the outbreak. But the problem with that constraint is it's not convex nor concave in general. So in this problem, in this research, we have reformulated this constraint and we use discretization to solve the model and in fact find the optimal solution for this problem. So for the next slide, I'm going to walk you through the way that we have reformulated this non-convex constraint. So in fact, we have to derive the value of reproduction number. In order to do that, we have defined the next generation matrix concept. Considering the biological interpretation, we are going to talk about what is every element in this matrix. So this matrix is, every element in this matrix shows the expected number of secondary infections in subgroup I in row. So the row of this matrix shows the susceptible people, the susceptible subgroups. So every row shows a subgroup and the susceptible people of that subgroup. So this expected number of secondary infections in this subgroup in the row caused by a single infectious individual from the other subgroup in the column. So in order to know how to calculate this element, we are going to look into, again, the transition that we are having in the population. So we define this using these two terms. So the first term, it looks very mathy, but I'm going to walk you through it. So remember from the epidemic model, the exposed individuals were transitioning to infected compartment with some omega rate. So 1 over that rate shows the expected duration of time that an exposed individual would remain exposed. And remember, while they are exposed, they can spread the disease, but they're not symptomatic. So that is the 1 over omega in this term. So the numerator here shows the expected number of people that one exposed individual would end up infecting during the time that they are exposed. So this is explained as the relative susceptibility of the subgroup that you're dealing with, their contact rate, and the relative infectiousness of that exposed individual. So multiplying that, you get the expected number of secondary infections in susceptible in the subgroup I caused by an exposed individual. Similarly, in the second term, you want to calculate the expected number of secondary infections caused by an infected individual. So if you remember, alpha was showing the recovery rate. 1 over alpha is the expected duration that an individual would remain infected. And while they are infected, if they are not quarantining, 1 minus p, if you remember, that's the proportion of the people that would not social distance. So if they don't social distance, considering the relative susceptibility, the contact rate, and the relative infectiousness of that infected individual, they would create the expected number of secondary infected people. So considering this biological interpretation, we have this matrix that shows the expected number of secondary infections in subgroup I caused by a single infected individual in subgroup J. So now we are moving forward to derive the value of reproduction number. Before that, we should talk about vaccine efficacy. So vaccine efficacy is a parameter. So that is something that we are assuming. So what means vaccine efficacy? I mean, that's actually interesting to know. So the vaccine efficacy is defined this way. So the percentage of reduction of disease in a vaccinated group of people compared to an unvaccinated group. So they compare these vaccinated versus unvaccinated, and they would measure the reduction of the disease. And they consider the most favorable condition. So under the most favorable condition, what is the reduction of the disease comparing the vaccinated versus unvaccinated? So for flu, normally that is between 50 to 60%. So considering this parameter and considering a matrix that is a diagonal matrix that shows the fraction of vaccination in every subgroup, then we form a new matrix D, which is the identity matrix minus the vaccine efficacy times that capital F. It's a little mathy, but just bear with me. We're almost done. So multiplying that new matrix D by the next generation matrix that we just talked about, then you can calculate the average number of secondary infections in subgroup caused by a single infectious individual after vaccination. So that's how you would see the effect of vaccination in the next generation matrix. So that is very similar to the definition of reproduction number. So we're getting very close. So it can be shown that RF is in fact the largest eigenvalue of this matrix. So we close the loop. So largest eigenvalue in this matrix is RF that we were looking for. And we know that if RF is less than or equal 1, then the outbreak is stopped. And if RF is less than or equal 1, then we can show that you have a positive right eigenvector that this relationship holds. Don't worry about it. It's very mathy. You can read the paper if you want to.
So quick question, Shakiba. The slide you just showed now, does that mean that we're talking about a failure of vaccination here? Is that right? That an individual who gets vaccinated, who otherwise might not have contracted the disease, but because they got vaccinated, ended up contracting the disease. Is that right?
So are you asking about the concept of efficacy? Efficacy means, if we say 50%, that means not everyone who gets vaccinated will end up to be immune.
I see. Yep, that's the point. Yes. Mm-hmm.
Yeah. So
yeah,
we may vaccinate people, but they may not end up to be immune.
Okay, thank you.
And the reality for influenza is 50 to 60%. With COVID, they are claiming 90%, which is very good if that's the case.
If Moderna came out saying it's 94.5%.
So we shall exactly. See. That was today. Yeah. Exactly. Okay. So now, considering this reformulation, then we can say, okay, this non-convex constraint can be reformulated this way. So we have this next generation matrix. We know the elements from the biological interpretation of the transmission of influenza. So we can have this reformulation, and the initial model was this, then we can reformulate the non-convex constraint this way. So this model is now, what are the decision variables in this model now? So you have F, that what we had was the fraction of people in every subgroup that would end up vaccinated. And this V is also a new decision variable that is the eigenvector of that next generation matrix. And that this is just normalizing the value of that eigenvalues. I mean, if you have any questions, I can answer, but I don't want to go into the excruciating math details. So this model is a nonlinear optimization because of this bilinear term. So you have f and v, they are multiplied by each other, so that makes it nonlinear. So you can solve this model optimally using a nonlinear programming solver, such as SCIP. But as the problem becomes bigger, then it becomes more challenging. So I'm going to talk a little about the solution method that we have developed, that is a global optimization algorithm. So we have developed this optimization algorithm for this non-convex bilinear model. So the way that we do it is this. So we have two subproblems, upper bound and lower bound. So we solve these two subproblems at some coarse level of discretization. So we discretize the landscape of this optimization problem. We solve these two, and then if we reach the precision that we wanted, then we stop. Otherwise, we have to increase the level of discretization. This is the general framework of our global optimization algorithm. I'm not going to talk about it in more detail. It's just too much math. So now we talked about the model very briefly about the solution. Now, the problem with the model I just showed you is this. So the only goal we had in that model was to contain the outbreak. But it is possible that the optimal solution recommended by model recommends vaccinating only one subgroup, because the only thing we care is to stop the outbreak. We don't really care about the way that we are distributing. For example, the model may end up saying, go ahead and vaccinate those that are more active in the population, go ahead and vaccinate young adults and school children only, and just ignore the seniors. And I'm going to show you that's the case if you do not enforce any sort of equity. And that's not going to be practical in practice. So we have to see some sort of equity when it comes to distributing scarce resources. And the concept is controversial. The way that is measured, the way that we deal with the equity is controversial. The way that we are enforcing equity in this model is using Gini coefficient, which is very well recognized in social welfare literature. So the Gini coefficient is defined over the fraction of people that are vaccinated, our decision variable, the fraction of people that are vaccinated in every subgroup. And in summary, I can say that what it measures is the amount by which individuals, every individual in every subgroup would receive vaccination. And this would be different from a scenario where all individuals would receive the same amount of vaccine. So how much we are, the policy that we are recommending is different from the policy that you would distribute completely equally among different subgroups. So the perfect equity would be 0. So if the Gini coefficient is 0, you're dealing with a perfect equity. And if it is 1, you're dealing with maximal inequity. So the way we are dealing with this is this way. So we are defining a level of inequity tolerance, and we are adding this as a constraint to our model. So epsilon is showing the level that we are going to be tolerant to inequity. All right, so let's talk about some numerical results to see what the model is capable of showing and recommending. So the goal in this set of experiment is to illustrate the usage of this model as a decision aid tool and assess the sensitivity of the results to the key epidemic parameters. So in this figure, first of all, we are dealing with an age-structured population. So we are having 5 different age groups. We are assuming there are 5 different age groups in the population. There is no equity constraint enforced for now. And we are using the data from past pandemic 1957 Asian flu. So the numbers you see at every bar is the amount of vaccine used per 1,000 people. The allocation to every subgroup is also shown. So for example, if the vaccine efficacy is 0.5, and if you do not do any social distancing in the population, then you should vaccinate 551 per 1,000 people in order to stop the outbreak. But what you can see here is the way you are distributing is ignoring completely the middle-aged adults and seniors here. So you're not really vaccinating two subgroups completely, because that would stop the epidemic. So, and as you can see, as you have the vaccine that is having a higher efficacy, then you don't have to vaccinate more people. So you would end up vaccinating less people if the vaccine works better. So now let's talk about the scenario. So we are keeping that no equity constraint in force, and the bar next to it shows the equity tolerance of 0.2. So as you see, if you want to be more equitable, naturally you have to vaccinate more people. And then you see that you're not having equality, you're having equity, right? So equality and equity are different. So you are vaccinating now every subgroup proportion to their vulnerability and the level that they would be exposed to the disease, and the tolerance you're considering is 0.2. An interesting observation was, as you are having a vaccine that is more effective, then the percentage increase between no equity and equity increases dramatically. So for example, if you're having a vaccine with 50% efficacy, and when you want to be more equitable, then you would end up vaccinating around 11% more people in total. Whereas when you are having a vaccine with 60% efficacy, you would end up vaccinating 68% more people. So if you have a resource that is working better, then in order to be equitable, you have to vaccinate more people. That is an interesting observation. So next, we tested the scalability of the model. So we considered larger instances in which every subgroup here is defined as a particular age group living in a certain geographic area. We estimated the next generation matrix and the population size using an open source agent-based influenza epidemic simulation called FLUTE. And we ran 20 replications of FLUTE using the population parameter files from metropolitan Seattle area. It had 560,000 residents living in 124 census tracts. So we started the simulation by seeding one infected person per age group in every census tract. So we ended up having 5 infected people times 124. In total, we started the simulation with 620 infected people in the population. Then we tested a range of 3 to 6 geographic regions. Each region includes 5 different age groups. We assumed 2 levels of vaccine efficacy, 50 and 60, and we assumed 5% of the population with social distance. So this is the outcome. So what we observe here is changing the vaccine efficacy from 50 to 60% results in about 3-fold decrease in the amount of vaccine distributed to contain the outbreak. And here also we see the optimality gap between the upper and lower bounds are quite small. However, here I just want to talk about the computational tractability of this problem. So if you consider a problem with 6 regions or larger, then it takes more than 2 hours to solve this problem. And remember, when we say 6 regions, we are considering 5 different age groups. That would be 5 times 6, 30 different decision variable for F, 30 for V. So that is a mid-size optimization problem. So the final thing I wanted to discuss is, again, the concept of equity when it comes to the coverage across different geographic regions. So in reality, the public health authorities might prefer to distribute the vaccine supply in proportion to population size of each region. For example, it might not be acceptable to vaccinate a different proportion of different geographic region, whereas it would be acceptable in practice to optimize the vaccination for different age group, because it's always well known that some age groups would be more vulnerable, but you can't really justify that when it comes to geographic region, even if that is justified by the model. So now we are going to talk about how we are seeing that in practice. So now we add a new constraint that informs a new condition. So we would say, okay, we want to have a uniform vaccine for each region, that is F. So we want to vaccinate every geographic region uniformly. Still, we want to optimize with respect to age. So considering that, we can modify the way that we define the Gini coefficient this way. So we can have the regional vaccine coverage, and we can define our Gini coefficient over that regional vaccine coverage. So we are still optimizing over age groups, but we are making sure that every geographic region is receiving the same amount of vaccine for the practical aspect of it. So this is just showing the difference between these two. So here in the left, you are not enforcing any regional vaccine coverage equity, whereas here you are having a uniform regional vaccine allocation. And the dashed line shows the regional vaccine coverage. And if you see it's not completely horizontal, it's because of the rounding issues. They are receiving the same amount of vaccine. So that is having a zero inequity. It's completely equitable. Whereas if you don't enforce naturally in this set of experiment, it has become 0.1 inequity level. So, and it just shows that when you want to be more equitable and you want to enforce to be equitable across different geographic region, again, you have to vaccinate more number of people. In this set of experiment, 4.2% more. And also in here, I just want to show that you can control the level of equity for the geographic regions. So here, for example, it is 0.04, whereas here your epsilon is 0.02. You are being more equitable, and as you see, some of the vaccines from other regions are transferred to region 2 to have a more equitable regionally distribution. So this is just showing that the model is flexible to accommodate different level of equity consideration when it comes to distributing the vaccine, considering different definition of the subgroups. So just to conclude, there are many different epidemic simulation models in the literature that would evaluate different vaccination policies before the implementation, and it is very crucial in order to make sure that the resources are being allocated efficiently. But this study goes beyond evaluating a given vaccine policy. So what is done in this study is prescribing and recommending an equitable vaccine allocation to stop an outbreak. And this can serve as a decision aid tool for public health authorities to let them know what would be the amount of vaccine stockpile that they would need to stop a future outbreak. For COVID, if we have the vaccine up and running, so every year, most likely we are going to deal with this problem just like what we would do with flu. So every season they would have to produce the vaccine beforehand, and then they would know what is the required doses of vaccine that they should manufacture, and then how to distribute it. And the way that we talked about the distribution, we considered the population is not homogeneous. We're dealing with a population that is consisting of different subgroups with different level of vulnerability and the way that they would be exposed to the virus. And this definition is flexible, and you can consider different definitions for subgroups as would be appropriate for the problem context. For this research, what would be interesting to consider for the future direction would be the fact that if you notice, whatever parameter we talked about, we assume everything is known and deterministic. So, but in reality, that's not really the case. So, for example, the vaccine efficacy is not really 100% known and deterministic. It's uncertain. So, and also even the parameter that we assumed for the transmission of the disease, the dynamic of the spread, for example, the relative infectiousness, relative susceptibility, these are also uncertain parameters. So considering the stochastic parameters, the uncertain parameters in this decision-making process is something that would be definitely interesting to look at. And also application of this modeling into other infectious diseases, such as COVID. I would be very interested to try this model into COVID data and see how this works out. So that would bring me to the end of this presentation, and I would welcome any questions or comments.
Thank you so much. We actually have a question in the chat that was sent to me by a student. Let me pull it up. It's from Anne, and she asked, "Is this same framework applicable to emerging therapies or therapies in short supply?"
I would say if the definition, it would require, if you can justify that the dynamic of the transmission is susceptible, infected, recovered, then you can easily apply the appropriate parameters in that context and then go ahead and use this model. Then I would say yes.
Okay, sounds good. We have another one, and this one's from Marissa. She asked, "What are your thoughts on the US's COVID-19 vaccine distribution plans currently?"
Well, that's actually a very good question. I think that is something that is not very clear to the decision makers as of now, but as I was following what's happening, so I think their plan is, well, first of all, they don't really know the available vaccine by the end of the year. So they know that the vaccine is going to be available by the end of the year, but they don't really know how much. So if they don't know that, then the distribution cannot be that clear. But I am guessing that they would probably, in their policy, they would focus on the people that are most vulnerable, for example, the healthcare workers, because probably that would make the most sense to do that. But as we would have more number of vaccine available and the vaccine can be proven functional, then I guess a more systematic way would be definitely needed, because even if we have the vaccine, we would definitely be dealing with this problem for the foreseeable future, just like what we were dealing with influenza, but it's not going to be as bad as what we were dealing in the past year, hopefully.
Yeah. We have another question. We have two more. This one's from Stuart, and he's asking, "Is the US planning on using any models similar to yours to inform their distribution decisions?"
I hope so. Well, our research group haven't been in contact with any particular public health decision makers, but I absolutely hope that they would consider a systematic way to make that decision, because that's definitely something that we would need. The researchers, this is the case for all other principles. We as researchers, we do work, we publish, but then how much of it is really being used in practice? There's a gap, definitely.
And we have a question from Cross, and he's asking, "Are there challenges in estimating the necessary parameters to use this model for COVID, given difficulties with testing availability and accuracy across subgroups?"
Absolutely. Well, this is a model, and whenever we say model, modeling means assumptions and parameters. So that is, there you go, that's the limitation. Whenever I teach optimization in the very first class, I remind the quote from that famous statistician that all models are wrong, some are useful. So, and then I'm like, okay, let's go home, right? What are we doing here? But the thing is, it's model. We need a way to deal with things, and you have to assume, and definitely the result would be very sensitive to the parameters that you would assume initially. But then considering all the computational power that we have these days with respect to collecting data and the way that we could actually try to estimate better, hopefully we can better tune the required parameters and hopefully have a model that is working better in practice.
And Eli, you can unmute and ask your question.
Awesome. Shakiba, great talk. Thanks for joining CHEPS for this. So I'm curious how so I come at these sorts of problems from the causal inference literature, which is obviously very different, but there's a lot of overlap. So I'm curious about things like, how does the model change, or how does like what you're doing, so the optimization side of things change if you assume that the distribution isn't stable, so you have kind of changing dynamics over time, similar to, that's I think a lot more realistic for an epidemic or an outbreak, because people have adopted social distancing in different to different degrees over time, and there's been kind of changing other measures outside of the scope of just vaccines or treatments.
That's a very good question. So the way that this model can be implemented, it's not really, you can implement this in a tactical manner, meaning that as the population is, as the state of the disease in the population is changing, you're flexible to actually adjust the change and the parameters and run it again and see what would be the best policy for the distribution, considering the current status. And that's why I was talking about the computational time for this problem. So it's not more like a strategic type of decision. You can run it in a tactical manner given the current status of the population.
But so at a given model run, I'm assuming fixed parameters rather than maybe dynamic parameters.
Yes, it would take, so the parameters that you would need to know is, for example, you would need to know the contact rates. Like first of all, you have to define, okay, what are those subgroups that you want to consider? Meaning that you are assuming that people in a particular subgroup, they're assumed that they are identical. So if you're saying healthcare workers, they're all identical for you. If you are saying school children in this particular geographic location, you're assuming they're all identical. So define the subgroup, whatever that, well, this is not really recommending what is the best way of defining subgroups. So you have to assume a way that you're defining subgroups. And then you should know in what rate different subgroup would be in touch with the other individuals from another subgroup within themselves and others. So that's another parameter that you have to assume. And then you have to assume every subgroup would have what level of vulnerability. That's called relative susceptibility. And then obviously that would be relative. So it's just a parameter that would show the relative susceptibility of different subgroups. Then you should assume the relative infectiousness of every subgroup. Again, that's another parameter. So then assuming all these parameters, then you can have the model tuned and have it run.
So quick questions, Shakiba. You gave an outcome that I kind of is a nail biter for me. I've been scratching my head. So there is this concept of herd immunity threshold, HIT, and I think it has come up in recent discussions with COVID-19. It's interesting that your results actually show that the number of people to be vaccinated, is a function of the efficacy of the vaccine in a way that I actually found counterintuitive, because your result was, I correct if I'm wrong, your result did mention that, the more effective or, the more efficacy a vaccine has, the more people will be needed to be vaccinated to achieve, what you call the phase out of the disease, which I would call maybe the herd immunity. So the question here is, how do you reconcile the fact that a more effective vaccine actually requires more people to be vaccinated to achieve you know,
Yes, good question. But well, let me show you the result, and that makes more sense probably.
okay.
Let me show you this. So well, here in this figure, as you see, I'm not enforcing any equity constraint. Okay, and then if I have a vaccine with higher efficacy, then I would need to vaccinate less number of people, as you expect. That is intuitive. Because if it works better, then it would, because of the herd immunity, then you don't really need to vaccinate as many people, right? But then if you want to be equitable, if you're, that was the interesting part. Then if you have the vaccine that is working really better, then if you want to be equitable, remember the second bar shows when you want to have equity considerations, then you would have to increase the number of vaccinations, because then now you have the resource that is working. Then you have
Thank you. I omitted the equity aspect. Thank you. And in fact, the funny thing about this is when you look at equity, I mean, we talk about democratizing energy access. We talk about health care. I mean, the whole idea of affordable health care, Obamacare, whatever, is about how many people are we actually reaching. And I think it speaks volumes about, you know, the basic definition of equity. So thanks for bringing that back. I lost that. Thank you so
much. Of course.
Thank you.
Very welcome.
Does anyone have any more questions? I don't have any more in the chat. Feel free to unmute.
So I have another one, but if anybody else.
Sounds good. You go ahead.
So it's actually kind of about this idea of equity. So I'm curious. So like Gini coefficient is kind of a weird. It's like very statistically grounded, and so it's kind of a weird thing to base equity off of. And so I'm curious, like maybe a thing for future work would be. I guess it's not really a question. A thing for future work might be like digging into other definitions of like fairness, because I know the machine learning community really has like, there's been an explosion of this sorts of stuff of like past specific effects and protect, you know, so like right now, like what's on this slide here isn't necessarily the like conventional protected characteristics that people look at. And so I'd be curious how, right, it's just a completely different optimization problem if you're using a different, you know, measure of equity or fairness or whatever. And so I think it'd be maybe interesting to dig into rather than just, you know, Gini coefficient.
Absolutely, you are absolutely right. This is a concept that is very controversial, and I agree that that Gini coefficient would not be probably the best way to measure equity, especially in this context. So when it comes to measuring equity, you can think about an input-based type of equity. So you want to distribute the resources in an equitable manner, or you want to be equitable as the outcome of a decision. Gini coefficient in this case is just trying to make sure that whatever resource you have, you can claim that you are distributing that in an equitable manner. But absolutely, there are many other different ways to consider equity. For example, we can think about deprivation costs that would measure the amount of suffer that people would have as a result of not accessing a particular resource. Maybe that would be a better measure for this context. But I totally agree with you that actually another research to see like what would be the best way to measure equity for this context. I agree with you.
Thank you.
Right. So with that, I think we can wrap up. Thank you so much, Dr. Shakiba. This was very, very interesting. And like someone mentioned, I really do hope that policymakers utilize your model when distributing the COVID vaccine. We can only hope. Dr. Cohn had to go because she has like a COVID emergency that she's leading. So she really apologizes that she couldn't be here. But she thanks you very, very much. And this was an amazing presentation. Thank you so much for coming and taking time out of your busy schedule. I know these times are crazy. So thank you so much for a wonderful presentation.
Well, thank you very much for having me. I really enjoyed presenting and answering great questions you guys had.
Thank you very much. Thank you, Renata.
Thank you. Good to see you.
Thank you.
All right.
All right.
See you,
Bye,
Eli.
everyone.